Thank you so much for agreeing to do this, Dr. Bernstein. Nice to see you.
Good, nice to see you,
All
Vinny.
right. So today I want to talk to you a little bit about the field that we're both in, healthcare administration, specifically dealing with quality, HEDIS, and what does that mean for the larger part of the people that don't really even know what HEDIS is.
Yes.
So before I did that, I want to dive in specifically just to get a little background on you, your experience after all these years, how you ended up here with your own consulting company, and here's a chance for you to talk a little bit about all your different accolades.
Thank you for asking. I'm a board certified internist. I have some training in geriatrics as well, and I'm an associate professor of clinical medicine, geriatrics, and public health. So it's a kind of a broad background for the field of healthcare because it touches on so many areas. My faculty position is at the Icahn School of Medicine, which used to be known as Mount Sinai. And I was in practice for 40 years. Have done administration almost that entire time in one way or another, either as a medical director of a group or as a medical director administrator of a practice. And for the last 7 years, I've been doing strictly healthcare consulting. So I've stopped seeing patients, but I've been doing the consulting work in the areas of quality, data management, risk management, geriatrics, and palliative care. So there's a variety of clients involved in quality and also risk management, because risk has become a very important element of quality as well as affecting reimbursement of doctors and incentives. So it's been an important element to my practice and what people will ask me about. I've written articles, chapters in books. I've given talks at national conferences about all these topics of quality and risk management and so on.
What's the biggest change that you've seen to risk management over the past, let's say, 5 to 10 years?
Well, the most important change really has been the idea that we've not only are measuring quality as kind of like a report card, but the report card now has teeth. It now directly affects reimbursement for health plans at one level and individual providers at the other level. Before then, it was always sort of, our plan has more quality points than your plan, but it didn't have quite the same importance. But since the government integrated reimbursement with quality performance, it now has taken on a very big deal because plans may earn less money. It may affect their ability to market all year round. And so not only is a bunch of gold stars, but it actually has a direct impact on reimbursement.
And that kind of goes into the next question, like what is HEDIS? But I'm sure that some people are just confused even on what that means.
Yeah.
And it kind of goes along to what you just were saying. But if you had to just describe HEDIS in general, how would you?
Well, it is an acronym that stands for Healthcare Effectiveness and Data Information Set. So the emphasis is really on data, but behind it is a population-based set of measures. So quality is not what happens when I see my patients. It has to do with a population of patients, and health plans are measured and practices are measured in not just who comes to see them, but in fact their whole cohort of patients or members that are under their responsibility. The measure for high blood pressure or diabetes isn't based on looking at the records of people who have had diabetes and come to your office. It will look at all the people enrolled with your practice or enrolled in your health plan, how many of them have diabetes or high blood pressure, and then that becomes the denominator, and then looking at the particular measures, like how well is it controlled, and so on. So it's different than the way most doctors think about quality. Quality, I'm a great doctor, I take care of my diabetics, I have them all under good control. Yeah, but what about the 10% that have signed up with your practice that you've never seen?
Right.
Or what about the 5% that you've seen but are, you know, homeless and can't get their medication and so on? They become part of the measure. So it's a very interesting movement in quality to go from simply the traditional look at the records, look at the compliance with the national guideline, to looking at the whole population and how are you managing that population.
There's something particular about HEDIS about the HEDIS data set that's changed besides what you just mentioned as far as what it means to plans, but actually about the data set. Have they? I know that they change them and they reevaluate them every year, every couple of years.
Yeah.
They reevaluate the data set. What have you seen the changes from when HEDIS was just kind of like a nice thing to have to you know, to on the report card, to having teeth as you described it? What has changed as far as the actual things they're looking at for the past few years?
Well, what's happened is that they keep raising the bar in terms of the standards. For example, what level of blood pressure control? What level of how are you defining people with certain conditions, and how does it compare to other practices or other health plans? So, for example, you want to look at blood pressure control. You're looking at people who you have to look at how well other plans are doing, how well you're doing compared to them. And as everybody improves a bit, then the expectation is that your practice will improve as well. So the standards keep getting higher, not dramatic jumps, but jumps nonetheless. And that really requires almost a re-engineering of how you manage your practice, how you manage your patients. Because you have to say, well, gee, last year this level of control was okay. Next year it's going to be harder. And so I have to get those people that are sort of borderline and get them into the control level as defined by the HEDIS standards. So that's the important thing, is that there's a continual effort to improve the population's health, and you do that by changing the benchmarks and the standards.
And now it seems like that makes, for the providers, it seems like that's like trying to hit a moving target. So what kind of innovations have you seen on the provider level that I guess good plans are I guess what's working now? What are some innovations that have to be made to kind of keep increasing with the measures?
Well, there's often a quality team, a STARS team. What these quality measures are evaluated in stars, either 1 to 5 stars. So there's often a STARS team that's very much devoted to reading about the latest changes, what's happening next year, getting geared up. When I say re-engineering, I'm saying people have to understand what is going on in the field, how are the standards changing, and what adjustments have to be made in how people are doing their outreach. So if people know, for example, that their blood pressure control level last year is not going to cut it next year, and they had a whole bunch of, 15% of the people had a good point system last year, had a good star rating, but it's going to drop next year given the new benchmarks, they have to then know that, and depending upon their communication efforts with their providers, they have to educate them and their practices about, alerting them to the newer standards. So it's a continual cycle of improvement, and it's hard. And like I say, it's not only the providers, but the members who have to be on board with this, and they have to know why there's going to be a tighter control, or why there's going to be some changes, and what was good last year may not be so good next year. So that's one of the major challenges, so to speak.
And that actually was one of my next questions was, why should patients care about HEDIS measures, and why should they care about helping their plan achieve that measures? I mean,
well, I think people want to know who's a, quote, good doctor. What's a good health plan to select from? And Medicare and other regulators have ways of flagging the plans. If they're not doing well, that's a problem. And so it's important for them to know who is good and why they're good, and do you want to be in a plan that got a sanction because their scores, their star scores, dropped last year.
right.
So it's by way of transparency and consumer information that people would want to know. And sometimes there's actually pricing differences, so that if a plan, for example, is doing very well, they can offer themselves to new members 12 months a year instead of just a briefer time spell, 6 weeks or so in the year. And they can take some of the money that they've gotten by way of incentives for quality and reduce their cost. So the plans that may cost less may actually have higher quality. And like everything else, when we're looking at the value of things, we want to look at price and quality. And so sometimes what is the most expensive is not the best quality. And so that's an important element of this too.
That's huge. That's
Yeah.
a huge part of this whole thing. Getting a deal.
Yes,
You know?
exactly.
How has this improved, rather, this increased focus on quality changed health plan administration?
Yeah.
I mean, you mentioned a little bit about the financial incentive, but I mean, there's so much that health plans need to do anyway. But now with this being more and more important every year, how much of the resources do they have to reallocate? How much more manpower do they have to put into to making sure they're dealing with their quality measures? Because like you said before, I mean, you go back over 10 years, it was kind of an afterthought, maybe, but now it's obviously a big part of the revenue.
Well, there's several elements of quality. We talk about quality as though it's a single thing. In fact, there are various domains HEDIS has divided quality measures into. There's access and availability, so you have to demonstrate that, in fact, your patients and members have good access to care, and that you're being effective in providing state-of-the-art quality care and preventive care, for example. There's a domain called the experience of care. So it's very much oriented to perception of providers, of the communication among the providers, how well the providers communicate with you as a patient. All that gets rated through surveys to the members. And if you don't do well in those, it's going to hurt quality and therefore hurt your reimbursement, hurt your reputation. So it's very important to be aware of all the new areas of complexity that HEDIS has added to quality measurement. And it all goes under this idea of performance. Right. And so, in the past, it was just sort of, well, I'm keeping my people with diabetes under good control. That's not going to cut it. If your diabetic members are unhappy because you're not communicating, or you're not doing something that is making them feeling listened to, you're complaining about side effects and you're not listening to them as a doctor, then that affects the perception of care and the experience of care, and people will will give you a bad or, a worse rating, a bad rating. And so all these become very important. And then, and lately there have been a risk adjustment utilization of services. For example, if you look at how many emergency room visits are made for people with diabetes, that can be adjusted by how severe their overall health is. And obviously, if you enroll a lot of very healthy people, you may have low emergency room use. You can't compare that with another practice that has very sick people.
Right.
And so one of the innovations that HEDIS has introduced is risk adjusting some of these measures so that you're really doing a much closer apples to apples comparison when you're looking at doctors' performance, but also health plan performance. So it's a much fairer system.
Right. And that's good for the end member.
Oh, yeah.
Because with apples to apples versus...
Yeah, so that when you see that a plan got a good rating, you know that that's been adjusted for how sick they are. And you're not going to compare the number of stars in a Medicare plan with a Medicaid plan.
Right.
And you're not going to compare a Medicare plan with a dual eligible Medicare-Medicaid plan.
Can you explain why? I know we're speaking in general,
Yeah.
but more or less the difference between the Medicare versus a dual eligible versus a Medicaid plan. How does...
Well, because people with Medicaid are in that, in Medicaid because of their income.
Right.
Because they have lower income, they're more likely to be sick, more likely to have other illnesses.
Right.
They're more likely to not have good education about healthcare issues, nutrition, and so on, and what are called the social determinants of health. And so people with Medicaid tend to be sicker, and if you look at Medicare, they tend to be older, obviously, but they aren't necessarily sicker. They may be, but not necessarily. But the important thing is you can't just compare people with an average age of 35, 40 with a group that's 70, 75, because we know there are major demographic differences that make those not comparable. When you introduce Medicaid and Medicare as a dual eligible plan, you have a sicker cohort of people who are seniors. And the question is, why are they in Medicaid, Medicare? It may be because they're disabled. And therefore their costs are going to be higher, they're going to be more complicated to manage. And so the challenges to the plan is greater as well.
Right.
So in the past, CMS, the Centers for Medicaid and Medicare Management Systems, I mean, Medicare and Medicaid systems, didn't used to adjust for people who had Medicaid if they also had Medicare. Mm. And one of the papers I wrote was about how unfair that was. And when you look at dual eligible plans who have both, you see there's just this gap between them in almost all cases. So it's in fairness and transparency, and to be able to, again, do an apples to apples comparison, it's important to adjust for, risk adjust for those differences in demographics and so on.
Who's doing it right? What are the plans that are really effective? What are they doing that's so different than a plan that's just, struggling with getting their scores up?
Right. Well, that's a good question.
Thanks.
What they have, going for them is a tightly knit system where often the doctors are used to working together. They're in an IPA, or an Independent Practice Association, or Accountable Care Organization, an ACO, but they're working under the same sort of incentive umbrella. And very importantly, they often have shared electronic medical records. Mm. The health plan can tap into that to track who's managing well and who isn't, and coaching those that are kind of falling behind. The typical plan doesn't have those kind of luxuries of everybody under a similar medical record system, of the communication links, of having incentive plans that they've developed to provide the right kind of carrots for those doctors who aren't doing as well, to show them how much more money they can make if they make these and this and that adjustment to their practice procedures. And so they have much better control over their networks, and they have much better control over their data. Remember, this is a data and information set, right? The DIS, the DIS.
Yeah.
So he who controls the data really is in the best position to get the most stars,
Right.
with the least effort, by the way.
Yeah. So if you, Dr. Bernstein, were going to be in charge of starting a new plan from scratch today, and you were fully funded, fully financed, what would that plan look like? Like, just I know we're talking of the global view, but what would be different? How would you like it structured? What are some of the innovations you'd like to have from the beginning? Maybe it can piggyback on some of the things you just mentioned, but how would you structure a plan?
No, I would definitely piggyback on what I just said. I mean, you want to start with a group of physicians that's used to working with each other. You have nurse practitioners in addition and physician assistants, but you have a group of providers that ideally know each other. Perhaps they work in the same hospital or hospitals. They have a medical record system that talks, everyone's record talks to each other. And so they really have a much better beginning. They're right out of the gate. They have a system to oversee what's going on with their patients. And the people in administration who are in the management service organization, which is an MSO, or the IPA organization that would oversee the back office work, they too would have this great insight into who's doing well and who isn't. When they can see which of their people with high blood pressure have it controlled. You don't have to go and into the record themselves in their office. You can do it remotely. And so having that advantage really puts you in great shape to monitor, to counsel, to educate the practices about how to really get to 5 stars with the least effort.
What is your opinion on the role that emerging technologies are going to play in healthcare administration in the years to come?
Mm-hmm.
Telemedicine, remote medicine, and maybe some technology that we haven't seen
Yeah.
put to a lot of use.
Well, we mentioned that access is one of the critical elements of quality. And telemedicine is not used often enough to address access. Now, why is there access? It may be because people live in rural counties where there just aren't a lot of providers, or they may have some providers, but not enough in particular specialties. And so there are several areas that have been particularly ripe for telemedicine. Optometry and optimal eye care in general, because it's so easy to get the equipment in to do the detailed eye exams remotely with just a technician. And as you know in your practice, how well that's working. But in addition, psychiatry or behavioral health is another natural, because you can do a video interaction with somebody and achieve almost the same degree of success that somebody is getting when they visit a practitioner in their office without the inconvenience. So that's another area that's growing tremendously in terms of improving access. Dermatology is another natural one. So teledermatology would be an area where you could imagine people expanding access. And you know, I think that taking a photo of a new rash and so on could save you a trip and cost, and yet the doctor can pretty much tell what's going on.
Right.
So those are the kind of innovations I think that are happening now. But no, those are the main ones. So you're in a field that's really ripe for expanding. And the more I tell my clients about what you have done, how you have helped our health plan in New York go from 2 stars to 4.5 stars in 1 year because of the way you operate and because you get into the home and now have integrated the telehealth into your practice, it really adds a whole other dimension to something that was not there before. And getting 5 stars in the diabetic measures where you need it for to achieve the best possible reimbursement. The eye exams are very hard because people don't want to go to the eye doctor. They don't want the inconvenience of waiting in the waiting room and so on and so forth. So being able to go to their home, be able to get the same quality of images is just a tremendous help. And I think the plans that use you appreciate what value you bring to them.
Thank you.
The National Committee for Quality Assurance, it was actually started 30 years ago, almost.
Oh, wow.
1990, as a nonprofit to focus on improving quality and access to care. And then it moved into the accreditation field. So it accredits plans that meet all their standards, and then it evaluates them using the HEDIS criteria.
Right.
So it was the sort of the midwife of the HEDIS report card. So yeah, so that's what NCQA fits, how they fit into this bigger picture.
What do you think is the future for how they interact with plans?
Well, because regulators like CMS or the state agencies that oversee quality depend upon the expertise and experience of NCQA and the HEDIS report card system, there's always going to be a need for them. Their expertise continues to improve. As they get more experience, they refine the measures, they make them fairer, they make them, I wouldn't say easier, but they make them more acceptable to the recipients, the health plan, who sit on and comment on, you know, how well this is working and what needs to improve. So they're very responsive to their kind of stakeholders.
Right.
So I think given their track record and given their track record of success and the fact that they have been responsive, I see a very bright future. Because we're always going to have to look at quality. We're always going to have to regulate in some ways, weed out those plans that are not serving the public, that are inferior in certain ways, and yet give them a chance to improve with very clear goals, very clear guidelines about how to improve. And if they still don't do it, then they'll lose their accreditation and won't be able to see Medicaid,
Right.
Medicare, and other groups of providers. And private employers also use HEDIS. In fact, HEDIS used to be called, used to stand for Health Plan Employer Data and Information Set, because it was totally based on commercial plans, but now that Medicaid and Medicare have joined it, the name has changed. Yeah.
That's a good nugget.
So it's a little trivia, but when I started, like I say, a long time ago, when HEDIS was just starting, I was one of the first reviewers. And so, back then, it was all commercial.
Right.
There wasn't any Medicaid stars and Medicare stars. It just didn't exist.
That's amazing.
Yeah.
Did not know that.
Yeah.
So we kind of went through a lot, and I want to just kind of leave with one last thing is if there's a plan that's listening, that's watching, and there's maybe their director of quality or one of the admins in their quality department is watching and they're struggling. What do you think? Obviously, we're not going to give a full assessment. We don't know who they are, but what do you think they could do right away to start improving with their overall quality measures?
Mm-hmm.
I know I'm asking a lot right now, because I know there's no silver bullet, but if there's any, what would be their next steps, do you think, that someone that was, that's administering or helping to administering a plan that they're really struggling in their quality scores?
Well, the challenges for each of the quality measures is different. There are like 90 different measures in HEDIS, and so you may be doing well in some of the clinical measures, but not doing well in the member satisfaction. And so the approach to improving patient or member satisfaction is radically different than improving that with high blood pressure control and diabetes. So it really is, every client is unique and has unique challenges, not only because the measures that they're struggling with may be very different than someone else's, some other plans, but because their culture within the plan may not be geared to quality, in the sense that the really top plans have a culture of quality. They very much think quality, they talk about it, they struggle with coming up with ways to improve it that are homegrown, but they also can go to the national conferences that are sponsored on quality, get tips from other plans, and meet consultants there who can help them develop a customized approach to improving their particular struggle, their challenges. So I would say, it's hard to make a generalization, but someone needs to do a complete assessment. Where are their strong points, where are their weak points, and what are the traditional ways that successful plans have dealt with improving their osteoporosis measure, improving their measures for, like I say, patient satisfaction. They all have very different approaches, and so it's hard to generalize, obviously, with that. But they're experts in all these areas, and so there's probably not one person who can do it all.
Right.
But there are teams of people who can go in and make a complete assessment and share best practices in quality with the plan administration so they can become a 5-star plan.
Excellent. Well, that was a wealth of information. I'm so excited we did this. I think that there's so much more that we can dive into, but we'll save it for another time.
Okay.
But thank you so much for talking.
Of course, thank you, Vinny.
I look forward to continuing the conversation. Thank you so much.
Sure, I enjoyed it. Thanks.